series. My name is Amy Peacock and I'm a researcher at the National Drug and Alcohol Research Centre, and I'm delighted to be with you all today for this webinar. Before we start, I'd like to acknowledge the traditional custodians of the lands on which we meet, which in my case is the lands of the Mawinea people, and pay our respects to elders past and present, and extend that same respect to any First Nations people joining us today. Today, we have an exciting and topical webinar with a fantastic presenter as well ahead of us. So today we're going to be hearing about the characteristics and toxicology of LSD and psilocybin-related death in Australia. And to cover this topic, we have an illustrious speaker, Professor Shane Darke. So Shane Darke is a professor from the National Drug and Alcohol Research Centre and is a leading world expert on the health effects associated with substance use. He has conducted extensive research on illicit drug use, including pioneering studies on opioid overdose, psychostimulant overdose, psychopathology, suicide, trauma, treatment outcomes, and toxicology. So quite a plentiful track record of outputs and expertise. We will have a number of panelists joining us at the end of the webinar. So what will happen is Shane will present and then we'll have time for questions from the audience. I would encourage you to please put your questions in the Q&A as we go along. While I may not be able to answer all of them, I'll do my best to put as many as possible to Shane and to our panelists. But I think we might get started. Shane, you ready to take it away?
I am indeed, Amy. Thank you very much, and it's a pleasure to be back in the ballrooms of Mars, which are looking beautiful. Look, today we've got quite a very serious topic, and a topic that's actually rarely researched. There's surprisingly little research generally on psychedelic related harm, let alone psychedelic related deaths, which is surprising given that they are, the extent of their use internationally. But I'd like to start by saying, well, people might be thinking, why do you study drug-related death generally? Well, I think there's two major reasons. One, I think we owe it to those who've died to understand who they were and why they died. All of these were potentially preventable deaths. And these were people's friends, relatives, etc. They have a big impact upon our society. Secondly, the dead have much to teach the living. By understanding who dies and why people die from using particular drugs, the hope is that you can, by understanding that, reduce future deaths. Certainly we've been in the area of opioids, we understand so much more than we did 30 years ago about what's causing, for instance, opioid-related deaths, and how we can thus react as a society and in public health to reduce the number of deaths and harms in the future. Of course, it's more than just preventing deaths. By understanding deaths are the pointy end of harm, and by understanding them, we can understand the broader harms. So today, we're looking at LSD and psilocybin. Now, psilocybin is mushrooms, magic mushrooms in the common vernacular. Let's just talk about what are they? Well, as I've said, they're psychedelics, or sometimes referred to as hallucinogens. LSD is a synthetic ergot alkali derivative. It's a synthetic drug. It has quite a long half-life. It's typically taken in blotters soaked in the drug, known as tabs, quite often with colourful pictures on them. So it's a completely synthetic substance. Psilocybin, on the contrary, is found in certain mushroom families. It's consumed in a number of ways. It can be drunk in teas. It can be baked into omelettes, etc. And more recently, we've seen powdered mushrooms in capsules, and that occurred in these cases here. I should just say that when we look in the blood of people who've taken psilocybin, it's rapidly metabolized to psilocin, and that's what will be found in the blood. That's the active metabolite. Now, why study these? Well, as I said, because even after 36 years in this field, it still staggers me that you come across areas and think, oh, hold it, no one's done anything here, or hardly anyone, or it was done 20 years ago. But there's been a lot of interest in recent years in use of psychedelics around the world, their potential for treatment in mental health disorders, for example. And this has raised a whole lot of general broader community interest. Now, it's very hard to measure the level of use of low prevalence drugs using household surveys or any other. We're very good at measuring high prevalence drugs like cannabis and alcohol and nicotine. Once you get down to the lower ones, it's tricky, but still you can see consistent broad trends. And the National Household Survey from 2019 reported 12-month use of just 1.6%. When you think of that's a lot of people out of a population of 27 million. If I was younger and my brain was operating better, I could probably tell you the number, but it's not. 2022, it had increased to 2.4%. That's quite a big jump from, I mean, we're still talking about a low prevalence, but it's a jump. And recently, there was a paper coming out of New South Wales looking at calls to the New South Wales Poisons Information Centre, which is consistent. They looked at 2014 to 2022, and the calls to this service more than doubled, which is consistent with an increase in use. Calls mostly concerned LSD. Whether that reflects prevalence or toxicity is difficult to know, or potency. There is evidence LSD has traditionally dominated over mushrooms in the hallucinogen field, but in more recent years, it does appear that mushrooms have increased to overtake LSD. So it's not clear where we'll be in 10 years' time. The types of things people were ringing the Poison Centre was concerns with hallucinations, gastrointestinal problems, tachycardia, that's racing heart, and frank seizures. So I would say that with any drug, rare events occur, but the more people use any drug, the more frequently you will see such events. Now, let's have a look at the harms. Now, I would just preface this by saying that there is no drug that is harm-free, entirely harm-free. It just doesn't exist. And that doesn't matter whether it's a synthetic drug or it's a natural product. All substances certainly may cause harm, and certain people may be more prone to experience harm, and of course dosage will matter too. So let's just briefly have a look at the various harms that are associated, we know from the literature occur. There's a number of cardiovascular harms we know are associated with the hallucinogens, psychedelics, these drugs. As I said, tachycardia, that's racing heart, hypertension, high blood pressure, and in extreme cases, heart attack, myocardial infarct. In a sense, these look like the types of effects we see with the stimulant drugs, such as methamphetamine, for example. But I would suggest at far lower rates than we see with meth and with cocaine. A number of other symptoms that have been reported, signs and symptoms, are hypothermia, that is high temperature, and that can be a stubbornly high and potentially dangerous increase in body temperature. vomiting, seizures. As I say, you can see that both tachycardia and seizures were things that were coming up in the poisons line in the previous slide. There's also more behavioural and psychological problems that can occur, adverse event. An agitated delirium, well, it's a term that's falling out of favour, but it's essentially, as it suggests, high agitation. The person's delirious, highly agitated, probably putting a lot of strain upon their cardiovascular system and at risk of injury to themselves or others. Now, the thing about hallucinogens is they're psychotomimetic, is that in a sense they mimic an acute psychosis in some aspects. And we do find in some cases there are people who develop psychotic symptoms during use. And now someone who's developed a psychedelic-related psychosis has a 1 in 4 chance of developing schizophrenia. So again, we're talking rare harms, but significant harms when they do occur. And finally, there's a HPPD, hallucinogen persisting perception disorder, commonly known as flashbacks. And that can be brief or it can actually be long, HPPD 1 and 2. And that can be very debilitating. And many of you may have seen there was a lot of media attention recently to such sorts of problems. So do not get me wrong. I'm not going to look you in the eye and say everyone who uses these drugs who is going to have these problems, because there is a lot of use and people don't have problems. But harms do occur. And as I say, any increase in use, you will see more harm of any drug. It doesn't matter what it is. The nature of that harm will depend on the drug itself. Now, let's move on to talking about mortality. Now, all drugs may cause death in different ways. Now, if we look at heroin, for example, overwhelmingly, the problem is that of overdose, respiratory depression, person stops breathing and dies. Their brain forgets to tell the body to breathe. Other drugs are different. That's not the predominant profile. In terms of drugs like LSD and psilocybin, the major acute mortality risk is traumatic injury. And that can be accidental, falling off balconies, crashing through plate glass windows, motor vehicle accidents, pedestrian accidents, this type of traumatic injury, or self-harm. Now, I've used the term self-harm there because, and I'll come back to this, that can be a impulsive suicide, and we've seen this with a number, certainly in the stimulant drugs, or it can be self-harm that does not appear to be it may mimic suicide, but it doesn't look like there was any intent. It's cutting oneself, for instance. There may be no intention. It's just maybe in a pseudo-psychotic state. So the major harm we see is because people are disoriented, particularly in cases of acute agitation, they're at risk of harm. But, and these are rare.
It's no problem. No problem.
Internationally, I think that was Professor Farrell weighing in. Internationally, we have seen cases of death that have been attributed solely to LSD or psilocybin toxicity. I think it's important to know that they can have been documented. They've been rare. Now, 2 cases recorded in the literature of LSD, one with a LSD concentration of 5 micrograms per litre. Now, I say that, what does that mean? Another one of half a microgram per litre in the context of hypothermia. Both of those were directly attributed by the pathologists and the coroner in the places where they occurred as being due to the recent ingestion of LSD. I say why is that the levels I wanted to point out are so low, they're so potent. In deaths related to heroin, for example, or indeed to methamphetamine, we see blood concentrations 40 times that. And it's just so low. I mean, drugs, in a sense, you see drugs like within the opioids, fentanyl concentrations are similarly way lower than heroin. Highly potent drugs can have effects at very low levels. And LSD, one of the problems of these has been indeed measuring it because it's so vanishingly low in its concentration in the blood. There have been deaths associated with psilocybin toxicity. As I said, psilocybe's what we look. One with 4,000 micrograms per litre, which is far higher again. But one with a cardiac arrest of 30 micrograms per litre. Again, these are low. The latter is low. The other one it's getting up there. But again, rare but real. And this is not me or my colleagues assigning these characteristics as a cause of death to these cases. These were international cases that the coroner and medical examiners in their place attributed directly to that. Someone took a drug and died, and there was no other possible known cause of death. So what did we want to do? We thought, well, no one has done a national study to see if there are any cases of death associated with this in Australia and how many there are and who they are. So we were interested in doing a study trying to find out, well, just how many cases can we see that have been attributed to these drugs, and who were those people and what did their tox look like? Now, I just want to emphasize, this is not a study of the efficacy of prescribing say psilocybin as a treatment. That's a completely different issue. That's an issue that is the province of clinical trials, and I make no comment upon that at all. Having said that, I think the information on mortality can give information to those who actually are prescribing these drugs or psilocybin at the moment, in terms of proven clinical practice. So I just want to make that clear. This is a study of people who died and who they were and what their circumstances were. So how did we do it? As I've said, we're looking at the circumstances, their characteristics, tox. I won't focus much on the major autopsy findings, except at the end to bring in one thing. Where do we find our cases? Well, the National Coronial Information System. This is the 8th wonder of the world. It is an outstanding system that Australia has developed, that all of the cases that come to the attention of a coroner, sudden or unnatural deaths, which will include drug-related deaths, are centrally entered. And I can look to searches, I can look at cases, whichever drug, of the police reports, the coroner's reports, the autopsy reports, and the toxicology reports, sitting in my office or anywhere from all around the country. No other country in the world does this. It's why we can do leading work and present national surveys. It can't be done in the US. It can't be done in the UK. And it's a real The people who run it are excellent, and they are highly commended for their work. So what we can do in that is search for LSD and magic mushroom deaths. We're restricted, and quite rightly so, to those 15 years or older. We looked at them over the entire history up to since the NSIS started in 2000 up into 2023. Now, NSIS has coding fields that say what are particular drugs were contributory to a death. And we could search for pharmaceutical substance for human use. In this case, you can do non-pharmaceutical, you can do anything really, it's extraordinary. They were contributory to death for LSD and magic mushrooms. They're the two fields that we look at. So what we're trying to do is capture as many as we can. Now, we will capture all of those that are so coded, but I will point out that, as I said, it's been two things. One, that the level concentrations have been so low, and two, haven't been part of the standard tox screen. I think that's changing. That there will be cases that we do not know of. We can only report on those where it has been measured, it has been determined it was present in the blood, and it has been determined it was related to that death. So, which is not our decision. That's the way it's coded by independent people. So what did we find? Well, we located 43 deaths. Now, again, that's when we think of this, the number of use, that's very low and way lower than we see in other drugs. Although I think it's slightly conservative. But 43 deaths have occurred that are being believed to be associated with the use of these drugs. 33 of them were LSD, use immediately preceding death. 10 of them magic mushrooms, psilocybin. Whether that's 3 to 1, I mean, that's consistent with what we saw with the poisons issue. Whether that reflects LSD having more harm, or whether it reflects, to date, the epidemiology of the use of the two drugs, I cannot say. And it's an interesting question in and of itself. It is possible that LSD with its longer half-life has a longer risk exposure. And we do see that with drugs, for instance, like methamphetamine versus cocaine. So who were these people? Well, they were young on the whole. The age of 24 for the LSDs and 28, that's the median age. But please don't think it's just, we got people in their 50s. We often think of drug use generally as being solely the province of the young, and it's not. Or at least if it was, it hasn't been for some decades. Almost all of these people were men. So what's our standard pattern? Young men. Majority either employed or a student. Now, I would say what that pattern looks like, the age and employment thing, look very much like the sorts of patterns we see when we look at deaths due to the new psychoactive drugs. And very different than we see, say, with opioids, where if I was presenting you a study on opioid-related death, the average age would be in the 40s and pushing up into the 70s for the top end. So this sort of figures, this is predominantly younger people, and that probably reflects the use patterns. They all occurred in an uncontrolled setting, and by which I mean a community setting. They did not occur in a clinical setting, although obviously it's only recently that psilocybin's been used. But what these were cases of people out in the community using illicit drugs and having adverse events occur. Again, consistent with a sort of a less drug-involved group of more like our MPS users. Substance use problems were reasonably minimal. the majority didn't have them. Again, as I say, that's very different than we see, say, opioids, cocaine, methamphetamine. Mental health problems, over a quarter. And given that we know that these drugs in uncontrolled use can be psychotogenic or cause anxiety and distress, that's a major problem. Affective disorders, majority, that's mood disorders, anxiety disorders, but a few cases of psychotic disorders. And one thing that we do not think people with psychosis should be doing is using a psychotogenic drug. So it's an issue in and of itself. And I don't know if people are aware of the harm. Now, that's who people were. How did they die? Well, as we've seen more broadly, the major problems concern traumatic accident. They were things like falling from heights, falling through, so falling off balconies, falling off cliffs, accidents of various sorts, motor vehicle accidents. But self-harm, that was particularly true of LSD, and it did not appear in the few cases we had of psilocybin. Now, I've used the term self-harm rather than suicide because there was the coroner in several cases noted that the harm done to the individual appeared to be impulsive and had no relationship to suicidal intent. That was so it was self-harm, that punching a hole through a plate glass window, for example, these sorts of things. And it's also, I mean, it becomes very difficult with self-harm. People falling off balconies, it's often said that, oh, well, they thought they could fly. We don't know that. We don't know that. People fall. That's all we can say. Other drugs are involved as attributing the cause of death. So that's multiple drug toxicity, including these drugs, in about a fifth. And there were no cases of single psychedelic toxicity or cardiac event for psilocybin, but there were a number of cases for LSD. Now, this is only the third case that we can report internationally that's occurred. And the profile was of hypothermia, cardiovascular events immediately following. And I would just say, like with single psychedelic toxicity, no other drugs involved. I would just say with these are not our categories. These are the categories that the coroner has attributed on the basis of the forensic pathologist and the police reports of circumstances, witness reports. There were 4 cases of psilocybin use preceding death were formally undetermined, but no other cause of death was identified, and they were identified. The term was basically used was a death immediately following the context of use. We've seen prominent cases in the media recently of similar types of things. I hasten to add, not included in here. Again, what I would say is I can only go of what it is, but these were deaths that occurred immediately following psilocybin use. So let's look at the clinical presentation. That is, and I'm relying on the notes of them saying what happened, and we don't always have that. That the severe agitation, and that was particularly in cases where someone's highly agitated, is hypothermic, is running around, and may cause themselves injury or put such stress upon their cardiovascular system they get into trouble. You can see about 10% of these cases just collapsed. And interesting, there seems to be a general pattern that there are more harms associated with the LSD. I wouldn't be too strong about it, but it's an interesting. Seizures, and hypothermia. As I've said, these sorts of things are actually the sorts of things we know are associated from the clinical literature and are actually the sorts of things we're seeing Poisons Information Service hearing. Now, I'll bring this, it doesn't really mean a lot to you, but I bring it up because I wanted to just stress again, well, there's two things. One, how potent these drugs are compared to other drugs. That, you know, as I said, you would expect something like, you know, 40 times higher if it was, or even more for that LSD. I should point out that toxicity cases were in the higher end of this range, as probably one would expect. Psilocybin, again, was higher, which is consistent with the earlier studies we've seen. But again, these are very low concentrations, and dosing is a real problem with a potent drug in a community setting. Now, I'll just raise again quickly, this is the LSD concentrations. What you're seeing there is what we see of drugs. It's very hard to say a level is toxic because people have different reactions or tolerances. And what we see is a broad range, quite frequently skewing towards the low end. We see it in all drug-related death. But you can, what I would like to point out is the maximum is some 50 times that of the median, of the minimum. And that is also true. The psilocybin, the maximum was 40 times greater than the minimum. You'll have things like body weight, etc., BMI, etc. But you will always see a wide variety. And if someone wants to say, I think this is the level that's toxic, we don't think you can ever say that for any drug. Too many other factors come into it. What other drug? There were other drugs present in about 3/4 of the cases. That's psychedelics were as contributory along with other drugs, as is probably not only surprisingly cannabis coming up there major. Again, the psychostims, very, you know, there does tend to be this confluence of those types of drugs. Alcohol, not so big. Ketamine, interestingly, again, we're getting this sort of an MPS, so you can see coming down there. I would point out, however, the cases of antidepressants and antipsychotics, which is consistent with the reports of the mental health problems that we've seen. Now, again, I will just point out that all drug-related death, the predominant presentation is multiple drug toxicity. That's indeed one of the major findings of the last 4 decades. And the problem there is always unscrambling the relative contributions. What we say is, and that in these cases, they have combined to cause this outcome, whether that be accident, or traumatic accident, whether that be whatever, toxicity of a drug. So taking stimulants and psychedelics may place greater pressure upon the cardiovascular system than taking one alone. So, all right. So what does this mean? Well, I always think we should end with implications. I can't stress enough that these are highly potent substances. The highly potent in very, very low concentrations. And there's a real risk of adverse behavioural reactions and physiological responses. I've talked about seizures, we've talked about hypothermia, talked about tachycardia, which may cause an arrhythmia. We've talked about that agitation that can cause major problems. People need to be aware of this. As I've said, whether a drug is synthetic or not, is irrelevant in terms of that it will have a harm profile. That's irrelevant, completely different from saying what are the benefits. And again, I will stress I'm not making any comment at all upon suicide in treatment. I think the risk has to be aware of people. If you're with someone who's tripping, or that there's a real risk of traumatic injury on, obviously driving, but people walk on roads, walk on railway lines, and fall or jump off balconies. Or there's that sudden explosive behavior that causes risk. I'm not sure to the extent that this is appreciated. I think these are real events that occur in the real world. And adverse reactions that occur, like we talked about, sudden collapse, hypothermia, person's temperature just won't come down, they're sweating, their seizures or chest pain. These all require prompt medical attention. One of the problems that we find across the board, and we've been doing, and I think there's some evidence in the fields, some fields like the opioids, we are making an impact. People need to call an ambulance. Someone's not just, if someone's got chest pain, a young person's got chest pain, call an ambulance. If an old person's got chest pain, call an ambulance. It's not just part of the experience. Now, I think there are clinical implications for those who are administering such drugs in a controlled setting. I think careful monitoring for the sorts of events that we've talked about is crucial. We cannot assume they won't occur. And I would suggest that people that have previous adverse events and or cardiovascular disease, I suggest that prudence would say extreme caution. If someone's had a series of extreme events with a drug, with any drug, it's generally not wise to prescribe it again. And what I would suggest and I don't think anyone's necessarily suggesting it occur, but I don't think we can talk about take-home doses. Unsupervised, these all occur in unsupervised use in a community setting. I think sending people home with doses is, in this case, appears to be contraindicated. And the other thing one has to be careful about is people don't develop a taste for the drug to use it in the community setting. Just finally, they're the two papers I've referred to. They're both available. They're open access. One is our one, the main paper here, and the recent Wilkes et al. On the calls that's just come out. So look, I look forward to your questions, and thank you for your attention.
Thank you, Shane. That was an absolutely fascinating webinar, as per usual, and really insightful findings from that study. I think it's quite important to see those results come through for Australia, contributing to that broader literature, and particularly as we see some indications of increasing use among certain groups in the general population to have some insight into those harms. I would encourage people to put their questions into the Q&A chat, and I will invite our panelists to pop their videos on. And just while they're doing that, I would remind anyone that if this has caused any distress, you can look to the helpline numbers that are available in the chat. But joining us today, we have Professor Michael Farrell to start with. So Michael has been the director of NDAC since 2011 and is a former professor of addiction psychiatry at the Institute of Psychiatry at King's College London, and with very extensive research interests, just like Shane, but including treatment evaluation, national and international drug policy. We may be joined by a second panel, so what I might do is ask you first, Michael, if you could give some reflections on the presentation from Shane, key take-homes, key areas of interest for you from what we've just heard.
Yeah, you can hear me?
Yes.
Yeah, good. Well, thank you very much, Shane, and very interesting work. Very nice to be doing it with you too. And I think as Shane has emphasized at the beginning, these are relatively uncommon events, but because they're uncommon does not mean they're not important. And it's not to exaggerate the harms, but to get a clear picture of them. And one of the things we are aware of is there's nearly an absence of literature on this. So actually, this information, even though it's uncommon, is important for us to have. It has to be said, if we look over 20 years with the notion of the number of episodes of LSD in particular, consumption that would have occurred, that the exposure rate is high and the mortality rate is low. But I think one of the more interesting aspects of it is there's a consistency in the picture. There's the picture of the agitated delirium, the fall off heights. A lot of these things are consistent with what we know. So people who know a lot about it will not be surprised, but to have it as an audit across 20 plus years is a very valuable contribution, and it becomes a critical reference for us. I think how it then gets more broadly interpreted from a policy point of view, I think we can have open for discussion in the group, but I think it's not uncomplicated.
Thank you so much for that, Michael. At the moment, we are having a few technical difficulties with our second panelist, so we might jump into some of the questions. I will present the questions that are put in the Q&A. As I said, please do feel free to add them. And just to note that as the questions are answered, they will disappear from the chat. It looks like, though, Wayne,
I'm here, but
you're
I'm
there.
out of my usual office, and the computer I'm using doesn't seem to want to allow me to use video.
That's okay. Well, we have the mysterious Professor Wayne Hall joining us today. Wayne is an emeritus professor at the National Centre for Youth Substance Use Research at the University of Queensland and a former director of the National Drug and Alcohol Research Centre. Wayne, even though we can't see you, you can still share your reflections. Any key thoughts from you before we get into the questions?
Well, I guess it's, as Shane has said, it's probably not too surprising. We've had pretty relentlessly positive media coverage of the wonders of psychedelics treating common mental disorders, which has probably encouraged a lot of more experimentation with these drugs amongst young people, including people with mental health disorders, as seems to have come up. And there might well be some misguided self-medication of depression going on here with LSD and psychedelics, which is probably not a good idea. I mean, I'm chronologically gifted enough to have been around the first time with LSD in the 70s in Australia. And, we saw a lot of similar events then when drugs get out and are widely used by unselected groups of people. You do get casualties. And I agree that we're talking about events which are relatively rare, but get to be more common when large numbers of people are using these drugs. And the sort of harm reduction advice that was developed, I guess, back in the late 60s on the west coast of the US and in the 70s here was sort of a bit like the designated driver, that that people shouldn't take these drugs on their own, that if they do take them for recreational or other quasi-medical purposes, they should do it in a group, and there should be at least one person in the group who hasn't taken the drugs who can protect other members of the group from doing things that put their safety at risk of the sort that Shane has been describing, and also intervene if people do have serious cardiovascular effects from these drugs, or become suicidal or develop psychotic symptoms. And I think we'd expect to see more of these sorts of events while the media remains so positive about the benefits of these drugs and downplays the potential risks in unselected people, particularly young people who might have mental health disorders, and especially those who might have been experiencing psychotic symptoms. I think the addition of a psychedelic drug to someone with a psychotic predisposition or already experiencing psychotic symptoms is certainly a bad idea. I think the other thing to remember is the risk, as I think Shane alluded to it, of people using these drugs who may be introduced to these drugs in therapeutic settings sort of self-medicating outside it. And I think we've had that's an anecdote I know, and it's a celebrity, but Matthew Perry was a recent case of a person who died, had been treated for fairly serious depressive symptoms with ketamine, but was self-medicating outside that setting. So it's something that people who are involved in seeking treatment using these sorts of medications should be discouraged from using outside control settings. And for those who don't accept that advice, then the sort of designated driver advice might be something that we should be putting out there for those people who are intent upon experiencing the interesting effects of psychedelic drugs.
Thank you, Wayne, for that. Always so wise, and I think some good precautionary notes there, and also some really practical advice in terms of harm reduction strategies. So let's turn now to our Q&A, and as I said, please feel free to add them all in. I'll do my best to fit in as many as possible. Just to kick us off, and Shane, I might throw this one to you. Do you know what other substances were tested for in the cases of psychedelic-only non-traumatic death? Do we have any insight into that?
What standard testing is? Their standard testing is for the full range of drugs. So they would test for all of the opioids, all of the psychostimulants, all of obviously alcohol, drugs like ketamine. They're broad screens. I suppose the only thing I would say to that is that there are, with the new psychoactives, we're always playing a bit of catch up, but people wouldn't just, when a death comes to the coroner, the forensic pathologist orders toxicology, and it's broad screening of all major drugs, not just the drug that you're concerned about.
Thank you for that, Shane. Just maybe if you've got some interesting comments coming through in the chat. Looking at one of the next questions that's coming through, there are cases of individual differences in biopsychosocial vulnerabilities, but would it be fair, do you think, or is there a case to be made that the serotonergic psychedelics maybe have a lower harm profile when compared to other substances like stimulants or opioids? Maybe Michael or Wayne, would you like to jump in with that first? Or maybe not. Maybe I'm going to Shane first.
No, Michael's got to just unmute himself. Ladies and gentlemen, we've got 3 old jokers with no technological skills whatsoever.
Am I in that group?
No, you're not one of the old jokers.
Wayne, you go ahead.
Sorry. I don't know is the short answer, Amy. I mean, it's an interesting question, and I think these drugs have been understudied from the point of view of their risks. I mean, LSD was interestingly originally synthesized for potential use in reducing blood pressure, so it was seen as a cardiovascular medicine. So the fact that you get these sorts of adverse cardiovascular effects from it's probably not too surprising. I don't know about psilocybin. I mean, the Dutch experience, Wim van den Brink and colleagues did a big analysis of adverse events amongst attributable to mushrooms in the Netherlands and found very, very low rates. I suspect that psilocybin is probably a lot less toxic, and in part because the effects last for a lot shorter period of time. Yeah. But if you're having a really bad experience with LSD, then you'd be having that bad experience for a considerable period of time, and that I can imagine could be fairly terrifying for people.
I think probably just comparing LSD and psilocybin, I think I did allude to. I mean, there were more cases. It's hard to know whether that's epidemiology or not, but the poisoning thing, it is possible, and the profile did look, it is possible it's has a longer half-life and is more potent. But I don't know, Michael, what do you think?
Yeah, I think when we look at subjective reported experience with LSD and psilocybin, psilocybin is consistently reported as a mellower experience and less associated with some of those, what you might call the bad trip type thing. So from that point of view, it makes sense. And as Wayne has pointed out also, that the shorter acting period of the psilocybin is the other factor that would, if one were having an inappropriately high dose, it would come down quicker than with LSD.
Thanks all for that observation. Moving on to another question that's come through, and Shane, I might start with you for this one. Looking at the cases that you studied, did you see a prolonged history of psychedelic use? Was there elements of addiction-like features or dependence-like features, or were there cases with, I guess, fewer occasions of use that in which then death occurred?
Look, I mean, it's difficult to say. I mean, look, with the older ones, I would find it, so someone in their 50s, I do not believe from memory and certainly from experience that they started taking it recently. It's probably more long-term. Use patterns tend to be more sporadic than with other drugs. But I would say that the low levels of substance use problems I'm not seeing, I'm not seeing evidence of severe dependence. But I think the issue I would say here is that a lot of this risk is an acute risk with anyone. If you take a drug like methamphetamine, it causes damage to the heart, and you have a cumulative damage and cumulative risk. There's an acute risk here that someone, I certainly didn't get the impression from any of these this was their first time.
Yeah, Shane, it is worthwhile reminding listeners that with LSD, you've got the tachyphylaxis, where if people were consistently using it, the effects dwindle quite a bit. So you would plausibly expect less complications, less of these acute complications in long-term heavier users, paradoxically.
One thing I would say, and because I'm 110 years old, I forgot, but in 5 of the cases, at autopsy, they had cardiomegaly, dramatically enlarged hearts. So the problem with that's showing systemic hypertension. The problem with that is once its heart's enlarged, its pumping efficiency reduces. You're at greater risk of arrhythmia. So even though if you've got, that's why I alluded to cardiovascular disease, even if you're not using a drug often, but you've got developing heart disease, that can have an acute effect that can land you in hospital or worse.
And I assume that we would assume that cardiovascular, the cardiomegaly and that sort of stuff is probably not related to the LSD use, but probably related.
I would suggest to me, it's either natural disease or possibly stimulants would be likely.
Or alcohol.
Or alcohol.
Yeah. Unfortunately, we're getting very close to the end of our time. I might throw this question to you, Wayne, just to quickly comment on. Do you think the profile of people using these drugs has changed from those using the same drugs in the 70s and 80s? Thinking about the role of social media, the discussions around health, mental benefits, microdosing, etc. What would you say around that, I guess, that change in profile of demographics, motivations, etc.?
Yeah, it's a bit hard to know. I mean, certainly back in the 60s and 70s, it was all about sort of mystical experiences and personal exploration. That was very much the reasons that people took it. I don't remember any emphasis on medical benefits. So it's possible that the media coverage of the use of these drugs in the treatment of depression and post-traumatic stress disorder might well be attractive to young people who are experiencing symptoms of those disorders that have not responded to existing treatment. So it's possible that we might see more higher risk young people experimenting with these. Certainly when I was doing my undergraduate degree, I worked for a time as a psychiatric nurse in an inner city mental hospital. And we saw a couple of young people with psychotic illnesses who'd gotten into trouble after using LSD. So the extent to which that might encourage experimentation of more vulnerable people, that would be a bad thing. But it certainly happened if you look at the experiences in San Francisco that were reported in the late 60s and early 70s. There were a lot of casualties there as well amongst young people, often troubled young people, and who were exploited and used by various others in that sort of cultural setting. So it has happened before, but I think the difference is the emphasis now on the therapeutic benefits, which might well attract a different group of people to experiment with these drugs than was the case in the past.
Thanks for those insights, Wayne, about what we think has maybe happened over time. Unfortunately, we're at the point of needing to wrap up, and I'm really disappointed because thank you so much for all the comments and suggestions in the chat. I'm looking at that and seeing mentions around use by spiritual communities, prevalence of polydrug use. Darren Roberts, thank you, author of, I believe you were author on the poison study, talking about the dose toxicity relationship and what we can infer from these studies. Points around stigma, and I think actually there's even a suggestion for a new study for you, Shane, if you haven't covered around DMT. Anyway, I will leave that for you there. Thank you all so much for joining us. Thank you to Shane for giving this webinar, to our panelists, Michael and Wayne, for joining us and giving us these insights. Before we finish, to excite you about what's ahead. So Thursday, 27th of June, we are changing tack. We're talking about the impact of gambling marketing on young people. And that webinar is going to be presented by Dr. Hannah Pitt from the Institute for Health Transform at Deakin University. And then a little bit of a break before we're back on the 11th of July. And sorry, we're not changing tack too far then, because we're sticking with gambling. Do increases in gambling expenditure lead to more crime? And we will be joined by Professor Don Weatherburn from the National Drug and Alcohol Research Centre, who normally throws an equation or two in, but it's always incredibly interesting. So I'd encourage you to sign up for both of those webinars. To register for the NDAC Symposium on the 20th of September in Sydney, and to enjoy the rest of your Thursday. Thank you all. Thank you, Shane, Michael, Wayne.
My pleasure, and thank you all.